So let's get started for today. And we spoke about in the first talk, I had mentioned that whenever we look at any cytopenia, whether it is anemia or low WBCs or low platelets, I look at conceptually, I look at the bone marrow as a factory. And if you take the analogy of a factory, then every factory needs raw materials. And the raw materials for hemoglobin are iron, B12, and folate. And like I keep on saying, of course, proteins, micronutrients, but these are the key three raw materials, excuse me, that the bone marrow needs. So iron, B12, folate. Now, you give those raw materials. If the factory has enough workers who are doing their job properly, then there will be production. And in the second talk, we spoke about what happens if that production of hemoglobin is is broken down or is lost. So how do we what is the approach to patients
अलग
where
अलग करंट इलाके रविश
yeah, just a minute.
अलग अलग करंट इलाके
So, what is the approach to patients where the raw materials of iron production is okay, but there is increased destruction, increased consumption of hemoglobin? Now, today we'll come to a more hardcore hematology topic of what if something is wrong in the bone marrow? What if something is wrong in the factory, right? And what are the different scenarios and how do patients present to you? Just a small review. What is anemia? Hemoglobin less than the normal range. And there are various definitions that WHO gives, and your textbook has hemoglobin less than 12, less than 13 in males and females. In my mind, a simple way to remember is there is a range printed on the lab report, which is below that, you can safely say there is anemia. But when hemoglobin starts going, until it is up to 10 grams, it is all right. But when hemoglobin starts going below 10, is when you have to really say, okay, I need to start evaluating. I can't just neglect and ignore. I can't just tell the patient, no, no, you take green leafy vegetables, you have non-vegetarian food or whatever. I have to start evaluating anemia, which when the hemoglobin drops below 10. Uh, Up to 8, we call it moderate. And when hemoglobin drops below 8, we call it severe. This 8 gram is also important because that is also our trigger for blood transfusion. If you look at the indications for blood transfusion, and I'm just reiterating what we have already spoken in the, discussed in the first talk, but just emphasizing this, that if you want to know, okay, doc, at what hemoglobin should I transfuse? Then I want you to remember just these two numbers, 5 gram percent and 8 gram percent. That's it. In nutritional anemias, so iron, B12, folate, and in autoimmune hemolytic anemia, AIHA. Okay, so nutritional and AIHA, your trigger, your target is 5 grams, keeping the hemoglobin above 5 grams. If the patient is stable in terms of cardiorespiratory status. So if the patient is not breathless, they are not in cardiac failure, they do not have coronary artery disease, you don't have to transfuse nutritional anemia and AIHA as long as the HB is above 5 grams. The second number is 8 grams. All other patients, whatever is the cause of anemia, the anemia may be post-op, the anemia may be road traffic accident, the anemia may be, hemolysis, which is not autoimmune, any other hemolysis, the anemia may be leukemia or whatever, 8 grams. So 5 grams and 8 grams are your two numbers. There has been quite a bit of research to see what happens if in the critical patients, in ICU or after cardiac surgery, what if you keep hemoglobin at 9 grams or 10 grams? Does it help those critical patients who have a cardiorespiratory or cardiovascular compromise? And the data is not ambiguous, it's very straightforward. It does not help. Okay. And in fact, by giving too many transfusions, transfusion, when we give, it is essentially another human being's RBCs, WBCs, platelets, and plasma proteins which are being transfused. And all of these elicit an immunologic reaction. And that is why it's very clear that even in most of the ICUs, the cutoff is now 8 grams. Some teams may say, no, we want to keep 9 grams, but that's fine. So 5 grams and 8 grams are your two triggers for transfusion. HB less than 6.5 is considered as life threatening, and unless it's a stable patient with nutritional anemia or AIHA, you need to give quick transfusion. In fact, these are the patients where you wouldn't mind telling the blood bank, hey, look, I want uncross matched O negative blood. Just go pick up O negative uncross match, and you can give the first unit if there is life threatening anemia, that is HB less than 6.5 grams. Now, coming to today's topic, like I keep on saying, inside the bones, we have the marrow, and marrow is a very unique organ because this is an organ which is spread across different bones. And like we have liver in one place and spleen in another place, bone marrow is not like that. Bone marrow is spread across the body in different bones. Um, That's the first aspect of the marrow, which is unique. The other aspect is if you have this hematopoietic stem cell, okay, hematopoietic, haima meaning blood, poiesis meaning creation. So the stem cell which can create entire bone marrow, then you can destroy this whole bone marrow with radiation and just put the stem cells, and that stem cell will create that entire organ, which is fascinating to me. And that's what we do in bone marrow transplant. That's what we do in stem cell transplant, right? What we do is, like the seed of a tree, like the seed of a tree can regenerate and create a whole tree with flowers and fruits and leaves. Similarly, this stem cell can recreate the whole bone marrow. You don't have to transplant the marrow, right? Like in liver transplant, you have to transplant the liver, you have to transplant the kidney. But in bone marrow, you don't need the whole bone marrow. You just have to transplant the seeds, the hematopoietic stem cell, and they will create the entire factory. And then factory creates RBCs, WBCs, and platelets. So let's see what exactly is this factory. I'm again going to go through this small table that I had shown in the beginning, that every factory needs raw materials. It has to have the right genetics, and the factory has to have workers. Sometimes the factory may be full of bad workers, people who can't do their job. And when these pack up, whether they are blood cancers or solid tumors, when they pack up the factory floor, the good workers don't have the space to do their job, right? So these are the two major scenarios that we'll be looking at today. We've already looked at increased consumption in the form of blood loss and hemolytic anemia. Let's look at what happens in the factory. So, what is bone marrow, right? It's a gel-like substance, and this is how the bone marrow looks. Whenever we do a bone marrow biopsy, we take initially we aspirate out, and we take blood, with some bone marrow fragments. That's called as the bone marrow aspirate, which is kept in a tube, anticoagulated EDTA or heparin tube, and we send it to the lab, and they take that liquid bone marrow and make a smear, and then a pathologist will look under the microscope, right? uh, that's the liquid part, the aspirate. What we also do is we take a bone marrow trephine, that's a biopsy. So the needle, which is of course hollow, we push it through the bone so that a cylinder of bone comes out, and we put it in formalin, and we also send the biopsy to the lab. So this is how a bone marrow biopsy looks under a microscope. You see these parts, this is the bone. Okay. And bone marrow inside the bones, it's inside the cancellous part of the bone. What is the meaning of cancellous part? There is a part of the bone which is like sponge. It's like sponge, like you have holes in the sponge, right? And if you take a sponge and you put it in a bucket of water, water will go inside those holes, right? And if you squeeze the sponge, water will come out. Similarly, this is the marrow inside the holes of the bones. Okay, this is the marrow. These are the cells. And when we send the bone marrow to the lab, our hematopathology friends, or when we see the marrow, we will first see, does this patient's bone marrow have enough cells, have enough workers to manufacture blood? Okay, so these are the tiny cells which are there, and these cells are called precursors. These cells are precursors. Why are they precursors? Because they start, these cells. Please, all of you, please mute when you join. Okay. So, what happens in the bone marrow is the stem cell matures, and it can then get committed. The stem cell can get committed to becoming an erythroid precursor, myeloid precursor, lymphoid precursor, platelet precursor. Okay, there are four broad cell types that we have. So the hematopoietic stem cell can go on to become an erythroid precursor, which makes the RBCs. Some stem cells will get committed to become myeloid precursors to create the granulocytes, so neutrophils, eosinophils. A third stem cell can get committed to become a lymphoid precursor to create T and B lymphocytes. And a fourth stem cell can get committed to become megakaryocyte, which is a platelet precursor. So you have RBCs, myeloid, lymphoid, megakaryocytes, right? Stem cells will divide and become committed that, okay, I am going to become an engineer. I'm going to become a doctor. I'm going to be a software guy. And, I am going to get into tailoring. I'm going to get into cooking. Similarly, the stem cells will get committed to become erythroid precursor, myeloid, lymphoid, and platelet precursor. And platelet precursors are called megakaryocytes. This is truly the way a child grows, right? So when a child is born in a family, everybody starts thinking कि ये बड़ा होके क्या बनेगा? What is he going to be? And then you think, well, this baby has unlimited potential. This baby can be whatever the baby wants, right? Whatever is the talent. It's our job to help them create that life. Similarly, a hematopoietic stem cell can become anything. I mean, any one of these four hematopoietic cells, I mean, blood cells. So they get committed into these four lineages. So those four lineages are right here. They're all here in between the holes in the bone. And here I can see there are a lot of cells. It's packed with cells. There is no space at all. So we say, oh, there are too many cells. And how do we decide how many cells are there? We decide it based on age. On age. A newborn baby's bone marrow looks like this. Normal bone marrow. The normal bone marrow of a newborn child is packed. It has a lot of cells. And as age grows, an individual who is 70 years old, there will be very few cells, only 30 or 40% cellularity at the most. Most of the space will be empty. Empty. What do we mean by empty? It is like this. See, this is how an empty bone marrow looks. You see this? I told you this is the triphyine, these are the bone spicules, and that patient's bone marrow had so many cells here, whereas this bone marrow is empty. It just has fat cells. Fat cells. It does not have any hematopoietic precursors. So this is an empty bone marrow. Hypocellular. This is what we see in aplastic anemia. Aplastic anemia, which is a bone marrow failure, that there are no workers in the bone marrow. And if we look at the aspirate under high power or oil immersion, this is how we will see it. You know what you are seeing here, these are just fat cells. And these dark dot, they are the nucleus of the fat cell. See, the fat cell has only fat. And at one end, you have the nucleus, right? At one end, it's like a ball, it's like a balloon with a nucleus. So, it's the nucleus of the fat cell. You hardly have any hematopoietic cells here. So, this is a hypocellular empty bone marrow aplastic anemia. This is also how bone marrow looks after chemotherapy. Okay. When we give chemotherapy for, especially strong chemotherapy for cancers, chemotherapy is like carpet bombing, right? So there are terrorists in a village, a plane comes, it drops 100 bombs, the terrorists die, and even the normal villagers will die. The carpet bombing technique cannot selectively kill terrorists, right? It is not targeted therapy. Similarly, chemotherapy will kill any cell that is multiplying. So when I give chemotherapy for Hodgkin lymphoma or leukemia, any cell that is multiplying, it can be the cell of a hair follicle, it can be GI epithelium, it can be bone marrow. All multiplying cells die whether they are normal or cancerous. And if I do a marrow after chemo, this is exactly what I will see, right? That all the normal cells have died. Of course, the bone marrow will recover. You know, if the chemotherapy is not very strong, the bone marrow will recover in about 2 to 3 weeks. But this is how it will look immediately a few days after chemo. So when we are doing a bone marrow exam, first thing we see if there are enough workers, if there are enough precursors. Then we actually see are all the three types of precursors there, three or four types, right? Erythroid, myeloid, lymphoid, platelet, megakaryocyte. So we go into high power and also oil immersion under the microscope and we start seeing. So you see this, these are cells, these are myeloid precursors. They will differentiate and mature and become neutrophils or eosinophils or basophils. You see, some of them have started becoming band cells and neutrophils. They are myeloid precursors. It's exactly like a small child who will mature to become a pilot or a cook, right? So these are myeloid precursors. Yeah, they will mature to become neutrophils. These dark ones are probably lymphoid precursors, and some of them are erythroid. Erythroid will mature to become RBCs. And this big thing, this big round fluffy thing, it's a large cell. It is a cell which has a big body, mega karyocyte. Okay? Mega karyocyte. Mega meaning big, karyos meaning body, right? Structure. And site means cell. So this mega karyocyte, this is one large, it is the largest cell in the bone marrow. And this mega karyocytes makes platelets. And you know how platelets are made? This huge thing is its nucleus. You see, the nucleus is multilobulated and the cytoplasm is fluffy. It's like, you get these the cotton candy, the sugar cotton candy that you will get in a fair for children, buddi ke baal as it is called in Hindi. So megakaryocyte cytoplasm is like that, and you see the cytoplasm will break off in pieces, and those pieces will be platelets, and you can actually see that happening. Can you see here at the edge? This cell membrane cytoplasm is breaking off and it is forming platelet, right? So, erythroid precursor will mature to become RBC. Myeloid precursor will mature to become neutrophil, whatever. Lymphoid precursor will mature to become T or B lymphocyte. Megakaryocyte sheds the cell membrane and cytoplasm. It sheds it, and that shedded particle becomes the platelet. Okay, this is the beauty of it. This is what we call as erythroid island. Erythroid island. Now, let me show you how beautiful nature is. You see this central cell where my cursor is, my pointer is, with a faint nucleus and a very faint cytoplasm. Okay? Faint nucleus, faint cytoplasm. This is a macrophage. It's a histiocyte, a macrophage. And the cytoplasm of the macrophage, it stores iron as ferritin. It stores iron. So this is the fixed deposit of iron, right? Like how you have money in the bank. So this is the bank which stores the ferritin. Now what happens is one stem cell will get committed to become erythroid precursor. Okay, so these three are the most immature erythroid precursors, and then they will grow, they will mature, they will take iron from this macrophage. That is why they are sitting around this macrophage. Okay, they will take iron and they will slowly mature to this stage and this stage and this stage. This is the nucleated RBC that I told you last time. And this nucleated red blood cell, this is the final stage of maturation of RBC. That will then squeeze through into the blood. The nucleus will stay back in the bone marrow and will get recycled, and what goes into the blood is the RBC. So this is how RBCs develop in an erythroid island around a macrophage which has ferritin. They take the ferritin to form hemoglobin. So these are some myeloid precursors, lymphoid precursors, giant megakaryocyte whose cytoplasm is shedding out to make platelets, and this one is an erythroid precursor. So this is how we try to see if all the precursors are there. Okay, they are there, but are they normal? Are they normal? Many times, you will go to places where you will think, yeah, this place has so many people, but they're all useless. They're not doing their job. It's just complete chaos. Nothing is happening. They are there, but they're useless. Now, these are the useless cells in the marrow that I'm showing you. Okay. Look at this normal megakaryocyte. It has a nice big multi-lobed nucleus. Look at this megakaryocyte. That nucleus is, first of all, it's a tiny cell. It's much smaller than the normal one. The nucleus is also single lobe. So this is a cell which does not look normal. In pathology, anything that does not look normal, it is not yet cancerous. It has not become cancerous. It's just looking weird. Okay, it's looking weird. That is called as dysplasia. Dysplasia. Like you have cervical dysplasia in the uterine cervix. Correct? You can have dysplasia of the buccal mucosa, which means the cells of the buccal mucosa, when you look under the microscope, they look weird. They don't look normal. Some patients will go on to get cancer, oral cancer. Similarly, cervical dysplasia, some patients will progress to get cervical cancer. Similarly, this is bone marrow dysplasia, where the megakaryocyte is looking dysplastic. This is what we see in a condition called MDS, which is our last talk on Friday, myelodysplastic syndrome. So yeah, the cells are there. They're looking funny. They're not normal. Probably in this patient, even though there are megakaryocytes, these megakaryocytes cannot make platelets. They cannot make platelets. So if you check the complete blood count of this patient, you will see that the platelet count is 10,000. So the marrow has cells. It has megakaryocytes, but they are bad workers. Abnormal dysplastic cells, they cannot make RBC, WBC platelet. Okay. Sometimes we see a completely abnormal cancerous cell. Blood cancer is of three types: leukemia, lymphoma, myeloma. I call it LLM, easy to remember. LLM. This is how a cancerous cell, blood cancer cell looks. It is called as a blast. We call it a blast. What is the difference between this and a normal myeloid precursor? It is bigger. The nucleus is not nice and clumped. It is, what we call open chromatin. And we are seeing that the granules are sticking to each other. You see this? And they're forming a rod. See that? The granules in the cytoplasm are sticking to each other and forming a rod. This is called as an OR rod. When we see an OR rod in the blood or bone marrow, there is only one diagnosis: AML, acute myeloid leukemia. So when we do a marrow, we look at cellularity. Does it have all precursors? Do the precursors look normal? Are there any cancers, blood cancer cells? Are there any cells in the marrow from some other organ having cancer? Now, this is a bone marrow of a breast cancer patient. Breast cancer, you think whenever somebody has breast cancer, you'll ask, what is the stage? What is the stage? Is it stage 1, stage 2, stage 3, stage 4? Generally, stage 4 in staging of cancer means metastatic, means the cancer is spread across the body. It may have gone to the lung or liver or bones. And if it has gone to the bones, and when you do a bone marrow, you will see these abnormal cells. These cells don't look like any, precursor in the bone marrow. First, and of course, it takes a lot of training to be able to identify these. Also, the peculiarity, the solid tumors, whether it is breast cancer, prostate, colon, whatever, they are called solid tumors. Solid tumors. So, solid tumors cells will stick to each other. Solid tumor cells will stick to each other and they'll form a lump. Correct? Breast cancer comes with a breast lump. You can see it in histopath. You see these cells are sticking to each other. So when if we see a clump of cells like this, we think, hey, maybe this is some kind of a metastatic solid tumor. But you look at blood cancer, leukemia. Blood cancers are liquid tumors. Liquid tumors. They spread out in the blood and bone marrow. They don't stick to each other. So, blood cancer cells are not in clumps. Solid tumor cells are in clumps. So, these are the things which we look for. Okay. But when we see this, how do we really know? Is this breast cancer cell? Is this myeloid leukemia or lymphoid leukemia? Is this really megakaryocyte or is it a plasma cell? Right? Just because I am telling you something is something, no, you have to have an objective way of identifying. You can't just depend on a hematologist or a pathologist. So, what is the objective way of knowing which abnormal cell or which normal cells are present in the blood and bone marrow? Okay. Now, let me tell you the story of this patient. This individual came with breathlessness and, had recently been diagnosed to have multiple myeloma, which is a kind of blood cancer, of course. It's a cancer of the plasma cells, right? And plasma cells make immunoglobulins, they make antibodies to fight infection. But sometimes the good plasma cell can become cancerous. Sometimes the police can turn into terrorist, right? It's like that. That's what happens with a good plasma cell, a good immune cell becoming cancerous, myeloma cell. Now, when a patient comes with this kind of, breathlessness, cough, and you do an X-ray, obviously there is a pleural effusion here. You can all see that. And you know that in blood cancer patients, their immunity is low. Maybe this is bacterial pneumonia, right? Those are your differentials. Your differentials are maybe it's an infection with a pneumonic effusion. Uh, can it be myeloma infiltrating there? I don't know. So what is typically is done is using ultrasound guidance or something. You put a needle, you take out a little bit of the effusion for testing. You do all the usual tests, albumin, cell count, and all that, and you make a smear. When you look under the microscope, you see these are all plasma cells. So that means this was what is called as a effusion caused by cancer. That means the myeloma has spread to the pleura. The bad cancer cells have spread to the pleura and they are secreting excessive pleural fluid and causing pleural effusion, right? and you can see it under the microscope. You do the right staining, yeah, these look like plasma cells. But can you know for sure? Of course you can know for sure. How do you know for sure? Because plasma cells are immune cells. So why can't these plasma cells be reactive because of, say tuberculosis? This can very well be tuberculous pleural effusion, and the plasma cells are just protective. How do you know they're cancerous plasma cells? And that is where a test called flow cytometry comes in. And I'll explain a little bit of flow cytometry. But in flow cytometry, what we do is we try to figure out what kind of proteins are there on the cell, what kind of proteins are there. And based on that, we can say, all right, this cell has CD38 and CD138 protein. This must be a plasma cell. This must be a plasma cell. Okay. How do we remember this? The way I look at it, in my mind, cancer is like a terrorist, right? Cancer cells are like terrorists. And imagine there is an Indian soldier on our border, okay, and he sees a person walking towards the Indian border. Now he has to think, who is this person walking towards Indian border? Is it maybe an Indian farmer who by chance crossed the border and now is coming back home? Is it maybe a farmer from the other country, a simple poor farmer who is coming towards the border? Or is it a terrorist who is coming? So, how do you separate out a harmless person from a terrorist? How do you differentiate a normal cell or a reactive cell from a cancer cell? Right? What will you do? You will first look at the person. What kind of clothes he is wearing? Is he carrying a gun? Does he seem threatening? Okay. Similarly, in pathology, we see what is the size of the cell, what is the color of the cytoplasm, are there granules or rods, what is the nucleus, how does it look to your eyes, right? You can dig in deeper. You can dig in deeper. You can ask him, show me your I card, show me your identity card. What does the identity card say? What kind of language does he speak? You know? So, by looking at people, we try to understand friend or foe. Friend or foe. Safe to shake hands with or no, right? Similarly, we dig deeper, and what we do in flow cytometry, like you look at an I card, an identity card, show me where are you from, show me your passport. Similarly, we look at the proteins on the cell surface, and that tells us what kind of cell is it, and is it reactive or is it cancerous. Okay. How do we do that? Because in cancerous cells, all the terrorists are the same type. They're brainwashed. They say we have to do this and we have to do this and we have to do this. So they are monoclonal. They're monoclonal, the terrorists. They start with one person who brainwashes them and everybody speaks the same language. Any terrorist in any part of the world, they're all the same, right? They're all monoclonal. On the other hand, normal people, when you talk to somebody says, yeah, I'm hungry. Somebody says, no, I want to do this, and everybody is different. So normal people are polyclonal. But when we do a flow cytometry, we can see that on these cells, all of them are only expressing this kind of immunoglobulin, and they are only expressing kappa light chain. They are not expressing lambda light chain. They are all monoclonal. That is how we understand that this is a bad cell, a cancerous cell. Now I'll just briefly tell you what is flow cytometry. What happens is when we send a patient's blood or bone marrow to the molecular lab, they will first centrifuge the blood and or bone marrow. When you centrifuge, you know that it gets separated into plasma, WBC, and red cells. Correct? There'll be three layers. I mean, this is first MBBS stuff. You all know this. After you centrifuge, with a pipette, they will take out just the WBCs and put these WBCs in another tube, another test tube. In that test tube, then they will put different antibodies. They will put different antibodies. Now we know that lymphoid cell expresses this antibody. We know myeloid cell expresses MPO, CD13, CD33. So you put in that WBC tube, you put anti-CD13, anti-CD33, okay, anti-CD38. You put all of these antibodies, put these antibodies, and then you wait for those antibodies to stick to the cell. After that, what you do is you wash it out. You give it a wash. And when you wash, what happens is whichever antibodies are not sticking to the cell will get washed out. Correct? If the cell is myeloid, anti-CD13 and anti-CD33 will stick. All of these other antibodies will get washed out. That cell suspension, then you put in this machine, this is the flow cytometer, one of the flow cytometers. So then you put the tube here, it will suck inside a little bit of cell suspension. That cell suspension goes through a flow cell, one cell after another. It's beautiful. One cell after another. They won't go through as a clump. There'll be no crowding. They'll go one cell after another in a single file, and a laser beam is put on it. And depending on which antibody is sticking to it, that color will highlight. So if the laser shows anti CD13 is there, 33 is there, then it's a myeloid cell. Correct?
ಕೇಳಕ್ಕೊಡು ನಿಂಗೆ.
And this is how we identify the different kinds of cells in the blood and marrow, and whether they are enough, whether they are normal or not normal. Now with this introduction, I'm going to stop and move on to the cases. Would you like to ask any question in between before we move on? Okay. So as usual, we only have two cases, and just a minute. So this is the first case, okay? Let's see what this first case is. This was a young boy, and he was, he came to us. This is about 2013, and he's a bright young boy, a proud son of his parents. He was in the last year of engineering, used to sing classical music, had performed on radio and TV, and he had gone through a couple of bad months. He was being treated by his GP and another physician because he had developed hepatitis, and 2 3 months, and then now the hepatitis had just started resolving. It had just started settling. His fever had gone, his appetite was coming back, and his liver function tests were improving. However, he came to them with fatigue, with generalized weakness. And when they did the blood test, they saw that although the liver function tests were improving, his CBC had now become bad. So the hemoglobin had dropped to 5.7, platelets had crashed to 18,000, and hence he was sent to us. Like I said, although his hepatitis had started recovering, he had started experiencing symptoms of anemia for about 2 weeks. And 2 months ago, he had fever and jaundice due to hepatitis. Although the platelets were no, there was no bleeding. He had not received any transfusions. There were no features of infection. So history in hematology is, history of low hemoglobin, low WBC, low platelets. Very simple. You would also want to ask about bowel and bladder because these can be sites of infection, urinary tract infection, etc. We always ask about weight loss because chronic problems can lead to weight loss as opposed to acute problems. So this was clearly an acute event. And of course, the past history, he had hepatitis. All the viral markers were negative for hepatitis, and he was just managed conservatively. And now his liver function test was improving. On examination, he had obviously pallor. There was some residual icterus, and he had petechiae because of low platelets on the arms, especially wherever they had tried to take a blood sample, the skin would, turn into an ecchymosis. But there were no lymph nodes. I told you, examination wise, there's nothing much in hematology, pallor, icterus, skin bleeding, and lymph node, liver, spleen. On examination, there was no hepatosplenomegaly. There was, of course, a hemic murmur because he had severe anemia. CNS wise, grossly, he seemed okay. So I looked at his blood reports. Hemoglobin was down, platelets were down, the WBCs were also down, and most of the WBCs were lymphocytes, 83%. Remember, in our WBCs, the most important WBC to fight acute infection is a neutrophil. Neutrophil is a soldier on the ground. Its job is to go and fight the bacteria. Okay. So when you look at a differential, neutrophils are always slightly more than lymphocyte. So, neutrophils will be 40-50%, lymphocytes will be 30-35%. So neutrophils are the largest number of cells in the WBC part. However, neutrophils and platelets also have the shortest lifespan. Shortest lifespan. They do their job and they die in a matter of hours or days. But lymphocytes can live for years. So, whenever there is an acute production problem in the bone marrow, your neutrophils and platelets will go down first because the production has stopped. Maybe 2, 3, 4 weeks ago, no neutrophils and platelets are being produced. Whatever was produced, they are now dying. But the lymphocytes live long. So you will see relative lymphocytosis. Relative lymphocytosis. Okay? Here the lymphocytes have not increased, but in relation to neutrophils, they seem more. Neutrophils are 17%, but we have to calculate the absolute neutrophil count, ANC. This is very simple. 17% means 17 out of 100. So how many in 2340? Simple calculation, right? So 2340 into 17 divided by 100. Absolute neutrophil count is 397. Why is this important? Normal neutrophil count is more than 1500. If it goes below 1500, it's low, but still not serious. If it goes below 1000, well, it's becoming serious. If the absolute neutrophil count goes below 500, then the patient has a very high risk of infection and they can suddenly die of neutropenic infections. This is neutropenia. Infections are because neutrophils are not there. So ANC less than 500 tells me this is serious. This is probably a problem in the marrow. So I look at the peripheral smear and I did not see any cancer cells. I just saw that, neutrophils are less. The liver function test again showed resolving hepatitis, probably non-A, non-B, non-C viral hepatitis. Kidneys were okay. What next? I sent off the LDH. I told you that LDH increases in megaloblastic anemia and in cancers. LDH was normal. This tells me maybe this pancytopenia is not due to B12 deficiency. Also, see the MCV is normal. Okay. So LDH, I did ferritin. Why did I send ferritin? Because sometimes in some infections, like hepatitis in this patient, the hepatitis can trigger our immunity and the immunity becomes overactive. Overactive. The macrophages, the histiocytes, can become overactive and start damaging the marrow. They can start damaging the liver. This is called as hemophagocytosis or macrophage activation syndrome. And ferritin is a very good screening test for hemophagocytosis because I have to see why is there pancytopenia after infection? Is it hemophagocytosis? No. In that, generally ferritin is more than 5000. Your ferritin is normal. B12 normal, folate normal, and I completed a bone marrow exam. In a couple of hours, I looked at the aspirate under the microscope and I saw empty marrow. You remember that first picture? Hypocellular marrow, right? This is exactly how his marrow looked. Empty marrow, right? Nothing. Marrow is all the marrow cells have died, the precursors have died, and only fat cells are remaining. The marrow is replaced by fat cells. This is a hypocellular marrow of aplastic anemia. Now, this gives me the diagnosis. This is a very straightforward diagnosis on the bone marrow. And yeah, the precursors are gone. You see, it's the same thing. These are all fat cells in the marrow. It all looks like an empty web, right? And reduced megakaryocytes are there. What do we mean by reduced megakaryocytes? Reduced myeloid, reduced erythroid means there is no production. There is no production. Remember, in ITP, there should be normal number of megakaryocytes. Here, there are no precursors, no factory people, right? And there are increased mast cells, which is one of the characteristics of aplastic anemia. I did not see any cancer cells, no hemophagocytosis. And this is how a hemophagocytosis looks. You see, I showed you some time back in that erythroid island, the macrophage. So this is a macrophage nucleus, this is a macrophage cytoplasm. And you see this macrophage is eating up this neutrophil. This macrophage is eating up these lymphocytes and RBC. So this is how hemophagocytosis looks. HLH, hemophagocytic syndrome. Okay. But this was not seen in this patient. So my diagnosis was post-hepatic aplastic anemia, which is a very well-known entity. We don't know why it happens, but because of hepatitis, it creates autoimmunity. It creates autoimmunity against the bone marrow. And that autoimmunity will kill off the bone marrow, causing aplastic anemia. It was severe because neutrophil count was less than 500. Absolute neutrophil count was less than 500. If it goes below 200, we call it very severe aplastic anemia. Okay, so this was severe post hepatic aplastic anemia. Now he is a young guy. When aplastic anemia happens in a person less than 45 years and he was 21 years, we have to think, was he born with some bad genes? And then hepatitis acted like a trigger and his marrow died off. So we do test. We do two kinds of tests, stress cytogenetics, and we look for hundreds of genetic mutation. At the same time, when anemia happens, we have two types of treatment. We can give immunosuppression because it's an autoimmune disease, or we can do a bone marrow transplant. Now, in young patients less than 40 years, the best success rate is with bone marrow transplant. And aplastic anemia is bone marrow failure. So, this is one indication for an urgent bone marrow transplant. Otherwise, the person will die of infection, right? So, while we are doing the workup, once we get the bone marrow report, we also send off HLA test because for bone marrow transplant, I need a stem cell donor. I need a stem cell donor who is well matched in HLA. We don't need blood group matching, we need HLA matching. So I send off the blood sample of the patient, his younger brother, and parents, and gave him blood, gave him platelets. He also had some fever after a couple of days. We treated him with antibiotics. That's neutropenic fever, right? That's serious. And his workup showed that there was no inherited predisposition, but in his family there was nobody who was a full HLA match, 10 by 10 antigen. Somebody was 5 by 10, somebody was 7 by 10, and this was 2013, when we would only do full HLA match transplant. Today, even if there is a 50% match, we can do it, right? But 10 years ago that was not the case, and you see how medicine has progressed in 10 years. Unfortunately, that time we said that no, no, you don't have any 10 by 10 full HLA match, so none of your family members can be the stem cell donor. Then what I did is I looked for unrelated donor in International Stem Cell Donor Registry, and I found a 35 years old lady in the US who by chance had a full 10 by 10 HLA match with this guy. And we then contacted the registry, and the lady agreed to donate. And in about a month or so, we did a stem cell transplant, that is bone marrow transplant. It's the same thing, just different name. But this was an unrelated full 10 by 10 match donor. There is a fantastic chance of success if you do it quickly in aplastic. And about 22 days post transplant, his marrow had recovered. RBCs, WBCs had gone over 4,000. Neutrophils were over 1,500 and platelets were over 50,000. So this is our first patient, a cause of anemia due to bone marrow problem. How do we approach? How do we diagnose? How do we look at the different cells? Second patient is also very unique. 56 years old lady. She was being planned for a knee replacement. My orthopedic friend, he called me saying, "Yeah, Sachin, I want to operate this lady, and her pre-op workup is by chance showing hemoglobin of 8.4, and I want you to just tell me that it's all okay. I can go ahead. I'll arrange one packed red cell for the surgery. So if there is bleeding, I'll transfuse intraop, but just pre-op, you please clear her for the knee replacement." So, everything starts with the story, with the history. She's never had anemia in the past. Now, why would a 56-year-old lady have low hemoglobin? Right? If a lady of childbearing age group has low hemoglobin, you will think of menorrhagia, iron deficiency. Why no, this lady who has never had anemia in the past, she's never had bleeding, no transfusions, no other systemic symptoms. Why would she have anemia? On examination, also, there was nothing much. So what do? You start with the basics. You look at the complete blood count. This is a hemoglobin. MCV is normal. WBCs are normal. Neutrophil percentage is normal. Platelets are normal. So maybe the bone marrow is fine. Maybe the factor is fine. Maybe it's still possible that she has nothing but iron deficiency. Liver function test was also, it seemed okay. However, if you look closely, the total protein is high. Albumin seems normal. But then what is the rest of the protein? So the AG ratio is reversed. AG ratio is reversed. See, this is the importance of understanding. This is an unusual scenario for anemia. Why will a 56-year-old lady who's never had anemia, even when she was menstruating, have anemia now? So do you take a proper history, look at the CBC, do liver function, creat, etc. And you see the total protein is high. Albumin is normal. So the globulin fraction must be high. Is there a problem with the kidneys? No, creat is okay, right? Ferritin is okay, B12 is okay, folate is okay. So then you start thinking, well, maybe there is something wrong in the factory, right? So how do I know? I thought, well, high globulins may be multiple myeloma, and it is common in this age group. High globulins can be normal immunoglobulins or abnormal monoclonal globulins in cancer. Monoclonal, I told you, all cancer cells, all terrorists are monoclonal, right? So monoclonal globulins because of myeloma. So I said, okay, myeloma also has lytic bone lesions. Lytic bone lesions. So I looked at her knee x-ray, knee which was to be replaced, and the knee had tiny lytic lesions. Now I saw that because I was thinking of myeloma. Okay, they were so tiny nobody would have noticed. My orthopedic friend, who's a great orthopedician, had missed it. You know, they were tiny, but because I suspected myeloma, I looked at it and I thought, hey, maybe there are lytic lesions. And so I thought, okay, maybe myeloma in the marrow, bad plasma cells, cancer, lytic lesions in the bone, their plasma cells are breaking the bone. Bad cells are not allowing hemoglobin to be produced. So now I told my friend, I said, buddy, I'm not sure what is happening. Give me a day or two to figure out what is the cause of her anemia, and maybe her knee pain is also due to myeloma. You were planning a knee replacement thinking that the knee pain is due to osteoarthritis. Maybe this is myeloma all along, right? And you see, this is a thinking surgeon, a thinking orthopedician who says, pre-op, let me just clear what is happening. He's a good surgeon, right? So he said, okay, Sachin, I'm going to postpone the knee replacement. You finish your workup. So I did a myeloma workup. I sent the blood for electrophoresis and found out, yes, there is an M band, monoclonal band of abnormal globulin, IgG kappa. Yeah. And this was huge quantity. You see, 5.6 grams. You see, 9.3 grams total protein, 3.5 grams albumin. The remaining part of total protein was the cancerous monoclonal immunoglobulin. Rest of the test also showed this is myeloma, and I did a marrow, and marrow showed monoclonal, same looking increased number of plasma cells. 36% plasma cells. I did a PET CT. Now the PET CT very clearly showed multiple lytic lesions in the skeleton. So final diagnosis was IgG kappa myeloma. And then my friend says, buddy, this is a malignancy. You treat this, and later on I will do the knee replacement. So he cancelled it. He counseled the family. Family was also, thankful that at least this was diagnosed before the surgery. So, like standard myeloma treatment, we give chemo, then we did an autologous stem cell transplant, and then we gave maintenance chemotherapy for 2 years. For bone strengthening in myeloma, we give bisphosphonates. They are prone to DVT, so we give aspirin to all patients. And within 2 months of starting chemo, her knee pain subsided. So obviously, she had come with knee pain. Everybody thought osteoarthritis, and they were going to do a knee replacement. All of that was myeloma, and it is not the credit is not to us. The credit goes to that orthopedician who said, no, 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 hemoglobin is low. First, you figure out what's happening. We did that, and she's expected to have disease control for about 3 to 4 years. But I saw her a few months ago, almost 11 years post transplant, and she's still in remission. So that is about today. This is just an overview of low hemoglobin because of a primary marrow production issue. Either the marrow is empty, or it has blood cancer, or it has other cancer cells. Of course, there are other causes also, but like I said, we're going to stick to the commonest problems that you are likely to encounter. Thank you. I'll be happy to take questions. Yeah. So how are cells washed? Well, it's you just Google online. It's nothing great. You put the sediment in a tube, centrifuge it, and the cells come down at the bottom of the tube like a button. You pour the supernatant. You put some more diluent, shake it, centrifuge it. Comes the cells come down. You pour the supernatant. That's how you wash the cells. Can flow cytometry be used to diagnose other conditions? Of course. I mean, flow cytometry is like immunohistochemistry. So when you put, immune stains on a biopsy slide, it is called immunohistochemistry. When you put immune stains in a cell suspension, it is called flow cytometry. It's used to diagnose. I mean, flow cytometry is used to measure the lymphocyte count in HIV patients, right? So it has multiple uses. Thank you so much, everyone. Such a pleasure. Sorry to delay today's talk, and I'll process and upload this video on YouTube tomorrow. I'll also share the link for the post test and send the PPT in the group. Thank you. Bye. Good night.